Going to present again my dear colleague, Professor Khalid الباسل. I hope that the technical errors
No, it's
are
correct
now.
now. It's already now.
Okay. His talk is going to be on Barrett's esophagus.
Excuse me, I'm sorry for the delay because the technical error. And at the first, I would like to present just short speech, welcome speech in Arabic. أولاً أهلاً بحضراتكم. شكراً لشركة سانوفي على دعمها للساينتفك ميتينج. chairperson أستاذنا الكريم الفاضل أستاذ دكتور حسين عبد الحميد، الزملاء الأفاضل دكتور رضا الوكيل، دكتور محمد. Thank you very much. وأتمنى أن تكون البرزنتيشن بتاعتي رغم التكنيكال ايرور is valuable for you. My presentation will be about Barrett's esophagus. This will be our hero, Norman Barrett, the one who first described and discovered what's meant by Barrett. And that's why it was named after him, after his name. In the 1950, Norman Barrett was the first who discovered that there is changing in the type of cells that lining the lower end of the esophagus. Because as we know, the lower end and all the esophagus actually is lined by stratified squamous epithelium that act as a protective layer and also as a secretory layer. He found that there is changing in the type of that cells from the stratified squamous epithelium to be columnar epithelium. Either columnar epithelium related to the gastric mucosa, which is considered to be a type of Barrett's esophagus known as gastric type of Barrett's, and the classic type is replacing the stratified squamous epithelium by columnar intestinal epithelium with goblet cells. Then he discovered that there is a relationship between the occurrence of Barrett's and the common disease, which we meet it today, a lot of cases in our daily practice, the GERD. He found there is a strong relationship between the patient complaining from gastroesophageal reflux disease and the development of GERD. 20 years later, they found that there is a strong relationship also between the Barrett's itself and the development of the second type of the esophageal malignancy, which is known as the adenocarcinoma. Because I think all of us know that there is main two types of esophageal malignancy. The upper two-thirds almost always develop in vulnerable cases squamous epithelium. Actually, squamous cancer epithelium. In the lower part, they develop adenocarcinoma, which is preceded by Barrett's esophagus. In the last 30 years, they found that there is increase in the prevalence of the occurrence of the adenocarcinoma by 6-fold. That's why it attracts the attention to the importance of that disease. When we're dealing with the case of Barrett's, we have to know the junction between the esophagus and the stomach. Actually, there is two junctions. One of them is histological, and it's known as a squamocolumnar between the stratified squamous epithelium lining the esophagus and the columnar epithelium lining the stomach. And the anatomical junction, which is known as esophageogastric junction. Almost always, both the junctions are at the same level, but it's allowed to be separated by not more than 1 centimeter. If there is a distance between the squamocolumnar from the esophageogastric that could be seen by the scope, we have to suspect the presence of hiatus hernia, which may share in the development of Barrett's esophagus. This is stratified squamous epithelium, and this is the picture of the columnar epithelium that replaced the stratified squamous epithelium as a result of chronic gastroesophageal reflux disease. Histologically, this is the picture of stratified squamous epithelium that replaced by columnar intestinal epithelium with goblet cells. It looks like actually you are seeing intestinal mucosa, not esophageal mucosa. Why Barrett's occur? How it occurs? Actually, GERD or chronic GERD will damage the stratified squamous epithelium lining the lower end of the esophagus. In normal people, this will be replaced by another stratified squamous epithelium because, as we know, there is 4 places in our body. The turnover of cells is very rapid. The GIT mucosa, the respiratory mucosa, the skin, and the blood. So in normal people, this damaged stratified squamous epithelium will be replaced by another stratified squamous epithelium. But in some patients who are risky, who have tendency to develop Barrett's esophagus will develop metaplasia, which means changing the type of the epithelial lining to the other type of epithelial cells. As I said, there is two types of Barrett's. Gut-exposed type to develop adenocarcinoma. This is one of the long segment Barrett. You see that one is very long, and this is the junction of the gastroesophageal junction. This is a short segment Barrett because it's just few centimeters above the Z line. Why we care about Barrett's? Because, as I said, they discovered that the patients who have Barrett's and have risk factors will actually develop adenocarcinoma. In spite of that, not every patient with Barrett's will develop adenocarcinoma. They found that just 5% from patients who have Barrett's will develop adenocarcinoma, but still attracting the attention to the increase the number of cases of adenocarcinoma. Actually, the Barrett's, to reach the stage of adenocarcinoma, should pass through two stages. The first is low-grade dysplasia, the type of cells that was firstly stratified squamous epithelium, then changed to columnar intestinal epithelium with goblet cells, will show some sort of changing the type of cells, the number of nuclei. But in a minimal picture, this is known as low-grade dysplasia. Then it will reach to the third stage with the high-grade dysplasia. This high-grade dysplasia is highly risky state because it will develop definitely adenocarcinoma at the last. This is the picture that we don't like to see it. This is Barrett's esophagus developed to adenocarcinoma. Which patient will develop Barrett's? Is any patients with GERD will develop Barrett's? Actually, no. There is risky group patients who have many risk factors predisposing them to change from just GERD that treated simply to develop Barrett's that you have to take care to avoid the predisposing factors to reach the adenocarcinoma. These risk factors are chronic Barrett, the chronic GERD, the refractory GERD, the patient who didn't respond to treatment, who have the GERD for a long time, is vulnerable to develop Barrett's esophagus. The old patient over 50, genetic factors, as we will see, that used as a biomarker to detect who is predicted to develop adenocarcinoma from complication of Barrett's. The male gender are highly predisposed to develop Barrett's. And finally, the obesity. The obese patients are predisposed to develop Barrett's rather than the slim patients. The prevalence of Barrett's is actually, if you have 100 patients complaining of GERD, you have to know that at least 10 of them have Barrett's, and you have to take care from that patient. A question, if there is a relationship between the common infection, as my colleague Dr. Muhammad and Dr. Khalid said, the Helicobacter pylori, which is very common in Egypt, if there is a relationship between the Helicobacter pylori and the occurrence of Barrett's, actually there is inverse relationship. They found that when the patient have Helicobacter pylori infection, the tendency to develop Barrett's is less. There is no actual explanation for that, but there is a theory that is not convenient for me, saying that the chronic infection by Helicobacter pylori may decrease the bulk, the amount of the parietal cell that secrete HCl, and that's why that patients with chronic Helicobacter pylori infection will not develop Barrett's. But I do believe this is not correct enough, because the chronic Helicobacter pylori infection is one of the most predisposing factors for the lymphoma, as we know, in the stomach. Now, how can we diagnose this Barrett? How can we follow this Barrett? The diagnosis actually depending on the using of the endoscopy. So there is another question. Should we do endoscopy for each patient complaining of GERD? بمعنى منظار لكل مواطن. It's not advised to do that. You have to select the patients who have GERD to do endoscopy for him, because the endoscopy procedure itself still carrying some complication. regarding the cost, regarding the anesthesia, regarding the risks of the patient. Many factors may interfere with doing the endoscope. So you have to select patients with chronic GERD who have the risk factors, who have the alarming sign that you have to do endoscopy for him. These alarming signs as dysphagia, bleeding, anemia or weight loss, age, obesity, this may consider to be risk factors pushing you to select the patient who have GERD to do an endoscope. So we have to start to treat the patients and follow the patient carefully, and if there is some of these risk factors, you have to carry the endoscope. When you are doing the endoscope, you have to describe the lesion carefully. As we said, there is two junctions. Mostly they are at the same level, the squamocolumnar site and the esophageogastric site, and you have to describe the Z line and to extend according to the length of the lesion of the parrots, and also the circumference of the lesion. So we have the maximum extension of the parrots, of the metaplasia, of the changing of the type of cells, and to extension along the circumference of the esophagus. Screening. Also, the endoscopy can be used for screening, but as I said, we have to select whom patients will be under screen. Those who have the risk factors. So, as a consensus, international consensus, they said that only the patient who have risk factors should be in the scope. Otherwise, you have to start by medical treatment and follow-up. Why actually we didn't do screening for all the patients? As I said, because you have to put it as a relationship between cost-benefit relationship between the hazards and the complications that occur even during the sample endoscopy. According also for the results, when you are taking the biopsy to diagnose parrots, it may be difficult to localize actually at the site of the squamocolumnar junction. And there is many folds that you can take the biopsy from the lower part of the esophagus near the stomach. And the pathologist said it's actually gastric mucosa, it's not esophageal mucosa. If you find a case of parrots, how can you follow it? How can you judge that that patient will not pass through the stages of parrots to low-grade dysplasia and then to high-grade dysplasia? This is what we call surveillance. Surveillance refers to following up the patients with the lesion. The surveillance is important because we have to know that facts, because if the patient has parrots but without dysplasia, we have to know he may develop adenocarcinoma, have risk factors about 2%. If he had low-grade dysplasia, the tendency for developing adenocarcinoma will go high to reach 7%. If he has high-grade dysplasia, that patients have the tendency to develop adenocarcinoma up to 22%. There is many consensus, international consensus have been discussed, the surveillance and the intervals that you should follow up the patients by the endoscope. All of them agree about the following approach. If you have patients with parrots and you diagnose it by biopsy, proper biopsy, you have to follow up him every 3 to 5 years. If he had just only parrots, just only intestinal mucosal cell without any dysplasia. But if you found dysplasia, low-grade dysplasia, you have to follow up these patients every 6 to 12 months by endoscope to avoid the silent progression of the disease to high-grade and then to adenocarcinoma. But if you have a high-grade dysplasia, the first choice is you have to deal with, as we will see together in the treatment of the parrots, you have to deal with this high-grade dysplasia. And if the patient refused, or if something prevented you to follow up, to do the treatment, you have to follow these patients every 3 months. So parrots with no dysplasia, you have to follow him 3 to 5 years by endoscope. Parrots with low-grade dysplasia, you have to follow him endoscopically from 6 to 12 months. If you have parrots with high-grade dysplasia, the first ideal choice is to treat this high-grade dysplasia. If not, you have to follow these patients tightly every 3 months to avoid the progression to adenocarcinoma. When you are doing the endoscope to diagnose Barrett's or to surveil that patient, you have to take multiple biopsy from different sizes that we call 4 quadrant, from the 4 parts, from the 4 areas along the circumference of the esophagus at different level, each level between it 1 centimeter. It was found that the surveillance of the cases of Barrett's decreased much the occurrence of adenocarcinoma. In 19, it was 1%. In 20, it reached 0.5%. And recently, by the proper surveillance of the Barrett's esophagus, it reached to 0.25%. When you are doing the endoscope, you have to select as much as you can the proper and the most advanced endoscope with better enhancement. And there is many other technology, for example, the chromoendoscopy, by using some dyes that will help you much in localizing the site of the biopsy and in localizing the site of the metaplasia that occur. For example, as you know, there is a dye known as methylene blue, which is absorbed actually by the columnar epithelial cell. When you flush this methylene blue during doing the endoscope at the lower end of the esophagus and then clear the other part by saline solution, you will find still blue area from the columnar epithelium that absorb that dye will still blue, localizing for you the site of the biopsy that you should take from it. This is picture showing us, this is white light endoscope. This is high resolution picture showing the lesion that was not obviously here. And then by using the narrowband image technique, which allowing passage of certain bands of light to localize the site of the change of the cells. This is by using the narrowband technique endoscopy. This is another picture showing what we call autofluorescent technique, as all the tissues of our body release some autofluorescent radiation. You can detect it by certain endoscope that localize the site of the lesion. And here, using the methylene blue. This is what we called endoscopic trimodal image. Your scope have the 3 characters, the white light, the autofluorescent, and the narrowband image. The Olympus endoscope have these characters. And then recently, there is what we call biomarkers. Biomarkers, something like the tumor markers, like the adjuvant test that you can use to select or to detect the disease, to know the progression of the disease, to know what about the response to treatment. These biomarkers in Barrett's esophagus, actually depending on the genetic study of the patients, and to differentiate between patients who have actually tendency to develop dysplasia and will progress to adenocarcinoma, and to differentiate those patients who will have Barrett and will not complicate it to adenocarcinoma, and also will predict for you the response of treatment. And according to that, you will modulate the treatment according to the case itself. This is showing us the genetic studying, and according to the genetic changes regarding the mutation or deletion of some genes, and increasing the oncogenicity or decreasing the suppressor gene P53, this will increase the tendency for progression from normal esophagus to the development of adenocarcinoma. What about the treatment of Barrett's? There are medical treatment, endoscopic treatment, and surgical treatment. The medical treatment, as we know, started by the PPI. Actually, the PPI will not treat the Barrett, but will treat the GERD that may reach the patient to the Barrett. So the PPI actually not directly treat the Barrett's, but may prevent the occurrence of Barrett, may prevent. In the patients with no risk factors, but in patients with risk factors, the Barrett's will occur whatever you do. Also, the PPI may help to prevent the progression of the low-grade dysplasia to reach to the high-grade dysplasia. So the PPI, just treating the GERD, relieve the symptoms, and may help to control the progression of the GERD to the Barrett's or the low-grade dysplasia to high-grade dysplasia in the non-risky patient. The endoscopic treatment, rather than the medical treatment, depending on either 2 things: removing the tissue of the Barrett's or the low-grade or the high-grade dysplasia, or just ablation the tissue. Removing the tissue means getting it out from the body. and ablation, removing the cells at the site of the body itself. Last thing, if there is stricture or obstruction occur as a result of that virus occur, or as a result of malignancy, by the endoscope you can keep the lumen of the esophagus patent. The endoscopic treatment regarding removing the area of high-grade dysplasia or even removing the area of Barrett's esophagus in vulnerable patients, in patients with high risk factors, you can use these modalities of endoscopic treatment: endoscopic mucosal resection or endoscopic submucosal dissection, radiofrequent ablations, or cryotherapy. And recently, they start to use the photodynamic therapy to ablate and to remove the low dysplasia and the high-grade dysplasia and even the Barrett's before. So, the international consensus recommend not to treat Barrett's from the start except in the vulnerable patients or in the patients with high risk factors to develop adenocarcinoma. But just patients with Barrett's, you just need PPI to prevent the progression and follow up, as we said, every 3 to 5 years. Then, if the patients had high-grade dysplasia or starting to have many risk factors predisposing him, you have to start to think about removing that tissue that will complicate it by adenocarcinoma. The removal of that lesion could be done by many types of endoscopic mucosal resection, some of them by using the snare, just using the snare to remove the area of the mucosa that you saw that is Barrett's esophagus. The other type by using banding, as we saw in the esophageal varices, making a polyp, then cutting it, or by endoscopic submucosal dissection. So, as you saw, this actually a mucosal disease. So there is a controversy. Is the AUS has a role in this situation? Just to remind you, this is the mucosa, the layer of the GIT. It's composed of the mucosa, submucosa, musculosa, and serosa. The tumor is classified according to TNM classification. T1 localized to the mucosa and submucosa, and T2, T3, T4 are extended to reach the submucosa. As you see, at that level, you can do endoscopic mucosal resection, but you can't do endoscopic mucosal resection or dissection at that 3 stages, because you will reach the musculosa that will predispose the patients for perforation and hemorrhage. Also, T1 itself is classified to T1A and T1B. T1A have lymphadenopathy with it. T1A is just localized to the mucosa. T1B is reached to the lymph nodes, so it cannot be treated endoscopically. That's why the endosonography helps much to look to identify if the patient's suitable for doing endoscopic treatment or he needs surgical treatment. And then nowadays accept endoscopic mucosal resection not only as a treatment way, but it's actually to stage the disease itself. So they started to use endoscopic mucosal resection not as a treatment, but actually as a staging technique to know to what extent the lesion reach. Is it reached to musculosa? Is it reaching to the lymph node or not? Then after staging that, they start to use the radiofrequent ablation, which is Stretta, to remove the tissues of the Barrett's esophagus or the high-grade dysplasia. Something you may think about as long as the Barrett's is predisposing factor to develop high-grade dysplasia and adenocarcinoma. So it's considered like the colonic polyp, because as we must know, that if you have the colonic polyp, we have to remove it because the tendency of the polyp to develop adenocarcinoma is very high. So they considered Barrett's itself, even without dysplasia, as a polyp. This is an idea that we have to respect it, but again, we have to deal according to the international consensus. So endoscopic eradication therapy is not suggested for general population with Barrett's esophagus in the absence of dysplasia. So we start to think about the treatment only in the high-grade dysplasia. This algorithm may summarize our speech. If you have chronic GERD with risk factors, you have to do endoscope. If there is no parrot, just treat the GERD. If there is parrot, you have to look if there is dysplasia or no. If there is no dysplasia, so you have to follow the patients every 3 to 5 years. If there is low-grade dysplasia, you have to follow the patients endoscopically every 6 to 12 months. If you have high-grade dysplasia, you have to remove this high-grade dysplasia, mainly in the highly risky patient. Actually, this is a clip for patients with parrots, and I did for him endoscopic mucosal resection using the band and then removing the tissue, as you will see now. Actually, as we are doing with the esophageal varices, we're making a polyp, including the parrot's area. Then by using snare, just cutting this polyp. It doesn't matter if you are cutting below the ring or above the ring. And you have to continue all through the circumference of the esophagus. This is an advanced stage of parrots that progress to high-grade dysplasia, then progress to the adenocarcinoma, and the patient reach to inoperable stage that necessitate, as I said, using endoscopic palliative treatment, just putting stent. This is adenocarcinoma at the lower end of the esophagus, and the patient is inoperable. So we start to put the guide wire inside. And then under screen, we have to know that the guide wire is going throughly from the esophagus to the stomach. And then by using what we call Savary dilators to make space for putting the stent. Here's the dilators coming in. Then we go by the endoscope after proper dilatation to check the extension of the tumor. Here we are in the stomach. By retroversion or U-turn of the scope, and you see the cardia from below, keeping the wire inside and then putting the stent over that wire. Putting the landmarks at the lower part of the tumor, just 2 centimeters below and 2 centimeters above, which is considered to be safe margin. And this is the stent coming down between the 2 landmarks, the above landmark for the upper part of the stent and the lower landmark for the lower part of the stent. And then start to deploy the stent properly. Here is after deploying the stent. The stent is in position and the lumen is patent. You may inject some dye through the stent and so the screen to be sure that the lumen is actually open. So in conclusion, chronic GERD, not responding to medical treatment with alarming symptoms necessitate endoscopy to check if there is Barrett or not. Barrett may progress to low-grade dysplasia that may progress to high-grade dysplasia and finally may progress to adenocarcinoma in highly risky patients. Esophageal cancer may be adenocarcinoma or squamous cell carcinoma, and recently they found that the prevalence of the adenocarcinoma increased in the last 30 years up to 6-fold than before. Endoscopic diagnosis, screening, and surveillance are important to minimize the prevalence of cancer esophagus. And recently, as I said, the biomarker, which means genetic studying of the patients, may predict the ability to develop Barrett's and to develop progression of that Barrett's to reach the adenocarcinoma. The American Gastroenterology Association surveillance recommendation is to follow up the Barrett's every 3 to 5 years if the patients have no dysplasia, every 6 to 12 months if the patient has low-grade dysplasia, and if he has high-grade dysplasia, you have to treat this high-grade dysplasia or to follow up the patients every 3 months. Endoscopic treatment is nowadays considered in this disease as an organ-sparing approach of therapy, better than doing oesophageectomy, which is have a high morbidity and high mortality. Knowledge is no tomato is a fruit, but wisdom is knowing not to put it in a fruit salad. Thank you.
Thank you very much, Dr. Khalid. I would like to ask you 2 questions.
Yes.
This is a very extensive and beautiful lecture.
Thank you very much.
First of all, the malignancy and the Barrett, the relationship between both. You gave some figures that in intestinal metaplasia of the esophagus, the rate of malignancy is 3%. And in low-grade dysplasia, the rate is 7%.
Yes.
And in high-grade dysplasia, the rate is 20%.
Yes, sir.
My point is, we have to stress that metaplasia have to go first in the stages of low-grade and high-grade dysplasia before it develops cancer.
Yes, sir. Yes.
I am sure you mean that.
Yes.
But the message to the audience, metaplasia does not directly go to cancer.
No. Right, you are safe.
And low-grade dysplasia do not directly go to cancer.
They have to go through these stages.
Through these stages.
Yes. Metaplasia at start, low-grade, and then high-grade.
These stages takes about 20 years.
Yes.
So this leads me to the second comment or the second question. I beg to differ with you a little bit about the results of screening of Barrett's esophagus. It is not as good as colon cancer.
Yes.
And sometimes say it is a failure and not cost effective.
Yes.
We have failed not to treat, to screen Barrett's esophagus. And this is surprising because the progression from intestinal metaplasia of the esophagus to adenocarcinoma of the esophagus takes about 20 years.
Yes.
So you have a chance to develop cancer esophagus, I mean to discover cancer esophagus before it develops.
Yes.
A very big chance, and yet it fails, especially when we know that surveillance of colon cancer has succeeded beautifully.
Yes.
By polypectomy,
yes,
as you said. So this is a question. Why do you think this difference between screening of both cancers? And attached to this, again, is your own impression about the prevalence of adenocarcinoma of the esophagus on the top of Barrett in Egypt. Because my own impression is that it is very low, in contrast to the international literature.
Thank you, Professor Hussein. Actually, there is 2 ideas. One of them overestimating the parrots because, as you said, there is high prevalence of adenocarcinoma abroad. But in Egypt, according to my experience, I'm actually working endoscopy in the National Cancer Institute about 17 years ago. And I found, but there is no actual statistics confirming what I said, it's just only my experience. I found that the incidence of the adenocarcinoma of the esophagus is increasing too much, up to, I am using stent, self-expandable metallic stent, in inoperable cases, about 15 stents per month. So actually I have seen, every 2 months I see a patient. So I think it's also increasing in prevalence here in Egypt. This is the first question. The second, I agree with you totally that it needs a very long time to develop from the parrots to low-grade dysplasia and to high-grade dysplasia. And that's why recently they started to think about the biomarkers, which could detect the predictability and the ability of the patient by himself. There is some patients have parrot and didn't develop dysplasia whatever along their life. And there is other patients, you saw him for first time with parrots, and then after 3 to 5 years, he started to develop high-grade dysplasia. So there is genetic differences, what we call biomarkers, that have been used now to study the genetic predisposing factor pushing the patient to develop that parrots. That's why the international consensus advised, if the patient has just only parrots, you have to follow him every 3 to 5 years. So this is go hand in hand by your idea. And if the patient has low-grade dysplasia, you can follow him every 6 to 12 months because you don't know that the rapidness of that low-grade dysplasia to reach the high-grade dysplasia. We have no the time needs from low-grade to high-grade dysplasia. And still, the low-grade dysplasia, to some extent, is still reversible by proper treatment, by proper removing risk factors that could be removable, because you know there is some risk factors you can't change it. For example, the gender, the age, but there is other risk factor you can change it. You can control the girth, you can control the obesity. This may reverse the low-grade dysplasia and prevent it to reach the high-grade dysplasia.
Thank you. My last point is very, very small. You said that we are having markers for the diagnosis of Barrett esophagus.
Yes.
Actually, I was expecting you to tell me that the reason for the failure of surveillance of
by using
Barrett,
this marker,
or at least the relative failure of surveillance of Barrett esophagus, is the absence of markers.
Yes.
Now you said there are markers.
Yes.
Are they plasma markers or tissue markers?
It's genetic markers
in the tissue.
Yes, genetic marker could be examined in the blood or the secretions or the tissue. Regarding the parrots, it's studied in the tissue itself. So you have to do endoscope and you have to take the biopsy and check the genetic markers inside the cell. But it's not valid. It's not valid in practice now.
We have that a long time ago. This is not true. This is not new.
It's still.
We have that before.
Yes, I know, but it's still not valid. It's still under research.
I mean, we are now waiting for simple plasma chemical markers,
I agree
which do not occur, which do not exist.
It's not
if we have this, the problem is over.
It helped much, definitely, it helped much.
Is there any further question in the floor? Professor Khaled, thank you very much.
You're welcome.
We'd like to focus or highlight the photodynamic therapy details because and the radiofrequency details for treatment of Barrett's. More information about this.
Information about the radiofrequency.
Radiofrequency and the photodynamic therapy.
The photodynamic therapy actually it depends on injecting some photosensitive materials like what we call photoferine. These chemical materials is absorbed mainly only by the malignant tumor cells. And then by exposing laser beam to these cells, you will necrose that cell, you will destruct these cells. So the patients need at first injecting the photosensitive material, and then by doing endoscope using laser beam, you will destruct locally just the cells of the malignancy that absorb the photosensitive material. But the drawback of this is the patients, if injected by photosensitive material, his skin will be exposed to the sun at any time, that may cause damage of the skin. And nowadays there is other chemical materials rather than the photofurin that does not causing damage to the skin. So it's not commonly used in the sunny countries as our country. Regarding the radiofrequency ablations, it's something like the balloon with thermal plates around it. You are putting it by the deployment system of it inside the esophagus and using the endoscope either above that, or there is some machines or tools could go through the endoscope, and you will see the thermal ablations will destruct and ablate the tissue of low-grade dysplasia or high-grade dysplasia.
Thank you, Professor Khalid. If there is any other question, we will close at this point. I'd like to thank all the speakers. حد تراجع نفسه يحب يسأل تاني قبل ما نقفل؟ آخر فرصة. أي سؤال، أي كومنت؟ طيب. Okay.
في سؤال هنا.
Let me ask you a question. Suppose you have a patient with simple GERD, without Barrett, and you put him on PPIs, say for 20 years. Is this patient, can he develop Barrett, or the PPIs for so long can protect him?
Number one, as I said, there is no any clue that Barrett's will prevent the progression. The progression actually is personal variation according to the genetic predictability and genetic factors that related to the patient himself. But as a consequences of disease, as long as we control Barrett, we hope by that we are as we are controlling GERD, we hope that we are controlling the progression to the Barrett. It may occur and it may not. We hope it may not, because it's proved that Barrett's does not occur by itself. It should be preceded by GERD. That GERD could be symptomatic and could be asymptomatic. And that's why when the patients have risk factors regarding the age, regarding the gender, regarding the obesity, regarding the chronicity of the symptoms of GERD, we have to treat him. If we treat him, we hope that this GERD didn't develop to Barrett, and this Barrett didn't go to dysplasia and then go to adenocarcinoma.
You mean to say it is equivocal?
Yes, it's equivocal.
Yes, I agree completely.
My question is pH monitoring for the esophagus impedance has a rule in diagnosis of Barrett before endoscopy? Impedance pH monitoring for the esophagus has a rule before the endoscopy?
That's it. It has nothing to do with the Barrett's itself, but it may help you to protect the GERD or the refractory or the non-responding GERD. So, keeping you to treat GERD properly, but it has nothing to do with the Barrett's esophagus.
Professor Khalid Hamida.
Thank you, Dr. Khalid, for your presentation. I want also to put a recommendation or conclusion. If we have 100 patients having GERD symptoms and we did endoscopy for them, you will find nothing in 60% of the patients. This entity is called NERD, non-erosive reflux disease. 15 or 30% of patients will have GERD, or erosive GERD. 9 to 15% of those patients can go to Barrett. None of the NERD patient will go to Barrett. So if you did endoscopy for a patient and you find NERD, non-erosive reflux disease, there is no need to repeat the endoscopy for screening for Barrett. But as Professor Hussein said, because we are afraid of progression of erosive disease to GERD, I think when the patient does not respond to our treatment, or if the patient got alarming symptoms during his treatment, we should re-endoscope the patient to search for that. Thank you.
Confirming your idea, Professor Khalid, the international consensus advised not to do endoscopy for the GERD itself, unless there is risk factors. But for GERD itself, it's not need to screen that patient.
We have another question here. Sorry.
The point Khalid raised may be correct because, you know, one of the risk factors is the duration. If you have a patient of simple GERD without any complication and he hasn't done endoscopy for 5 years before, then it is time to do endoscopy,
Yes.
just to follow up. So this is an alarm factor, the long duration.
Yes, yes, I said the chronic GERD is
Yes, I
one
agree
of the
with
risk
you,
factors.
but just to clarify
Yes, yes.
what happens.
Mike.
Thank you, Dr. Khalid, for your presentation. I want to ask you about the mucosectomy when you said that when you do band ligation of the mucosa and you do a splenectomy below the ring or above the ring. Is this maybe hazardous and maybe developed to make perforation of the esophagus, or maybe if you make splenectomy below the ring, this may be hazardous to the patient and may develop perforation to the esophagus or no? And yes. You said there is no difference between below and above. You don't need any hazards from that.
Any more questions يا دكتورة اتفضلي.
How about recurrence after endoscopic treatment? Percentage. يعني هل الريكورنس بيبقى عالي ولا لا؟ what about the follow up after ablation? Okay. And هل بيحصل normalization للاسوفاجيال ميكوزا or not؟ لو حصل سواء كان high grade أو low grade أو حتى even metaplasia. Thank you.
Actually, it's a very good question. I think the third slide showing that when there is a damage for the lower end esophagus, in normal people it will be replaced because there is rapid turnover of the epithelial tissue lining the gastrointestinal tract. It will be replaced by stratified squamous epithelium. This is in normal patient, in normal people. But in patients with Barrett's, as we said, and as the discussion with Professor Dr. Hussein, the patient himself has genetic tendency to develop Barrett's and to develop dysplasia. So when you will remove it, we hope that these cells will be replaced by stratified squamous epithelium. But actually, you have to follow up him because still that patient is predictable to develop Barrett's again. Okay? If there is no symptoms, you deal him as a normal people. If the start there is a symptoms of GERD again, you have to refollow him at the consensus agreement.
I have another addition, Professor Khalid, that there is always concern about leaving some cells of intestinal metaplasia just below the ablated area. And there may be nests of metaplasia, submucosal metaplasia, or subsurface metaplasia. They may represent a future risk of developing cancer.
I agree with you 100%, and that's why I said the endoscopic mucosal resection that was considered as one treatment, now considered to be just only as a staging technique to know if the dysplasia reaching or the high-grade dysplasia reaching deeply in the mucosa or not. And they started to use the radiofrequent ablations, as Professor Reda said, which deal with the whole area above the Z line and below the Z line, and not leaving single cell that may redevelop again cells of tendency for adenocarcinoma. I agree with you 100%.
Thank you.
Yes.
The surgical treatment of cancer esophagus is very awkward.
It's horrible.
Because total esophagectomy
It's horrible.
is a heroic operation.
It's horrible.
And it's very bad.
Yes.
In your own knowledge, is there any update in surgery about Barrett esophagus?
Up till now, no.
Some modifications for surgery, Khaled. They are keeping
I
selective
don't know.
vagotomy and doing a very limited surgeries. There is some talks in the literature about this, but still it has a very high perioperative mortality, and the quality of life after the operation is very bad.
Yes.
And it's better to deal with the problem endoscopically rather
yes.
than to do.
And that's why the
surgery.
endoscopic treatment is known as organ-sparing treatment.
Okay, okay. I think we reached to the end. Now we had achieved some gaining some time to spend in the break with the break time. Please let us stick to the time of the second session. We'll be here at 9:15.
Now you are invited formally to the break.
Thank you so much. Thank you, Professor Khaled.